How are you, Sam?
I'm good. How are you?
Should we do an intro of ourselves? Is this what we do?
Go ahead.
Hi, everyone. Welcome to episode 7 of Sam and Tiff Talk Science. I'm your co-host, Tiffany. I'm a scientist entrepreneur, currently in 2 biotech companies, a cancer vaccines one, university spin-outs called Infinitopes, and early cancer detection one called Gambit Bio that I co-founded during my PhD at Oxford.
Scientist entrepreneur. That's cool, no?
You have a cooler one.
What's mine?
Clinician scientist.
Scientist. I like scientist entrepreneur. That's good.
You can be a clinician scientist entrepreneur.
Yeah, we should just add like more and more and more.
Yeah.
Like
more to the stuff is
how many hyphens can you add before you get
endless.
endless, right?
Yeah.
It's like my LinkedIn profile. Yes, you're a scientist entrepreneur. I'm a doctor scientist, clinician scientist.
Oh, I like that. Doctor scientist.
I feel like I don't know if everyone knows what like clinician scientist means.
Dude, let's go into that for a bit.
Okay.
Yeah.
And that's why I say like doctor. I know no one says doctor scientist. I know no one says that.
Yeah.
But at least everyone knows what a doctor is and everyone knows what a scientist is.
Exactly. But it's a bit, because if you say doctor scientist, it sounds a bit redundant.
Does it?
Because they'll think that the doctor comes from the scientist part, but they don't know that it comes from like the medical doctor part. I know.
That's how I think. Yeah, but yeah, I see what you mean.
But it's okay. You have a PhD and an MD, basically.
That's what it means.
Yeah.
And yeah.
But I mean, tell me if it's wrong, but PhD doctor came before the medical doctor, right?
Me?
In terms of the,
Oh, sorry. Yeah.
The naming, the etymology of it.
I think that's right. The original doctor was the science doctor. And you know that even so they never used to call surgeons doctors. And even in the NHS, I don't know about around the world, but in the NHS, you don't call, there's this weird pathway for a surgeon where they're not called Dr. blah, blah.
Uh-huh.
They're called Mr. or Mrs. blah, blah. Do you know this?
I didn't know that.
So if you have a surgeon and their name wouldn't be Dr. something, it would be Miss something.
That's crazy. So they can open you up and like perform a surgery on you and still not be called a doctor.
Yes. So they are a doctor because the way it works. So you go like before you become a doctor, you're a Mr. or Mrs. and then you're a doctor and then you become a surgeon and you go back to Mr. or Mrs. Yeah.
That's crazy.
But it's very prestigious. The surgeons would definitely not like them to be called Doctor something. They would say, "Oh, I'm not Doctor something. I'm Mr. something."
But
I think it comes from the. I want to say it, I might be making this up. I want to say it comes from like the hairdresser days.
Hairdresser days.
Is that a thing? Or the
oh my gosh.
barber days where they used to be like. I've probably made that up.
This is mad. I'm learning this for the first time.
Yeah.
So
Anyway,
but wow, I never thought about that.
Yeah.
Because next time I go on a plane, if they see that I'm a doctor, because I always have to clarify I can't save anyone's life if they have a heart attack or something.
Yeah. You can make them a vaccine real quick, like a cancer vaccine.
Just give me 1 weekend, I'll make you a vaccine.
Do you want to talk briefly about what happened in Harvard this week?
Oh yeah, let's do it. Do you want to? What have you seen on the news as of 2 days ago?
Well, you tell us. I think you're closer to this than I am.
So, the Trump administration has decided to revoke Harvard's right to enroll international students, and it's a bit, chaotic and sad. I just feel like they're taking away everything that America is known for, like freedom, free speech, intellectual freedom, prioritizing, pursuing the truth, academia.
But they've stripped visas as well, right?
Yeah.
Of people already in labs doing work in Harvard.
Yeah.
If you're a student, PhD student over there doing work in a lab, and you're an international student, then you might have actually lost your visa.
Yeah, because it's tied to a specific institution. But if that institution, like Harvard, has lost its rights to host these people, then the visa gets revoked as well. So, and the timescale at which it happens is really scary.
Yeah, like so fast, right?
Exactly. And you would think that, science transcends borders or education transcends borders. But yeah, how do you feel about it as a Brit?
Well, as a Brit, I mean, I guess what the Brits can do is benefit from that, right? Because all of the talent that's now in Harvard
Do you think like they can hire?
can come to the UK. So it's bad for the US, it's bad for the students, but maybe it's good for Britain, right?
Yeah, that's
Because then we
that's a
can,
good
we can take
point.
some of the talent. I think a lot of the talent would international talent would pick the US over the UK, wouldn't it? Usually, typically. I mean, you didn't.
Oxford's not too shabby.
No, it's pretty good. It's pretty good. That's true.
Yeah, and it's not too far from here. It's only a 5-hour flight, so it's not, the other side of the world. So
Yeah.
maybe, yeah. But yeah,
Okay. Should we talk about breakthroughs?
yeah. Anyways, yes, it's
Oh,
important
one
to
of them.
comment.
I feel like one of them is from Harvard, by the way.
Oh, really?
Yeah. Which one's from Harvard? One of them's.
Is it the gene editing one?
No, the third one's from Harvard. So that shows you. Yeah, it is the one about.
Goes to show
malaria.
you how
Shows you-
important
There
international
you go. Harvard's
collaborations
important,
are.
right? Harvard's important.
It is very important.
I feel like I need more coffee before we start. Is that okay?
Yes, of course. Go ahead.
I've just necked that, but I need a little bit more. My brain isn't quite, buzzing yet.
No, go ahead. Go ahead. My friend texted me. She's like, "Who does your editing? It's so good." I was like, and she's not talking about the first one, which is really good.
Yeah.
Yeah.
Okay.
Anyways,
so
so
we're back. I got some more coffee.
All right, we're all good. Cheers.
So number
All
one.
right.
Should we talk about number one?
Yeah. So these are the scientific medical breakthroughs from May
yes. So
2025.
The biggest. So in our opinion, the three biggest medical breakthroughs from May, and I'm just checking where this is from. I think it's. I really should know where it's from. I think it's from a study from people in France, if I'm not wrong.
Yeah,
check.
I think it's
Where's it gone? Where's the first one from? Are they in France? I think.
I should know this. Philadelphia.
Oh, sorry, Philadelphia. Apologies. So in the
Oh,
US.
Berkeley.
Oh, is it?
Of course, that's where CRISPR's from.
So it's-
And Harvard. There you go.
okay, good.
Harvard, Berkeley, of course. Where's MIT? I just assume anything to do with
Everything's- it's
CRISPR
gotta be
is
in
to do
there.
with MIT and Berkeley. All right, so
Okay.
the first breakthrough from May is a landmark approval from the FDA. It's base editing for a super rare genetic disease that got made and approved all within 6 months, which is insane. And it was used on this infant who was born with a mutation in CPS1. And that just means that they have elevated ammonia levels in their blood. And the mortality rate is quite high for this disease. It's 50%, I believe. Make it out of the early infancy.
Yeah. So yeah. Overall mortality rate is 100% by adult. No one makes it to adulthood.
Yeah, exactly. So this was a huge deal because they were able to make a bespoke gene therapy for this baby by the 7th month of its life, and it's really effective.
Exactly.
Yeah.
So this broke 2 records. This breakthrough broke 2 records. So the first is it's the fastest that any medicine has ever been produced from scratch to the patient in history.
That's the first first record.
So like you said, so absolutely from scratch, never been. They didn't even know what they were doing at all. They didn't even know of the existence of the patient, and then they had it done, ready to go. Studied everything in the patient in 6 months.
It's insane, and it was approved in 1 week by the FDA.
Yes, exactly, yeah, which is insane, and they've got a beautiful kind of chart to show how that worked. The other record is the first ever patient-specific gene editing.
Yes. So unlike other gene therapies that can be administered to anyone who has that specific type of mutation or that disease, this is a very specific mutation to this patient for this already ultra rare disease. I think is it 1 in 1.3 million people have this disease. And CPS1 stands for, I'm going to butcher it, carbamyl phosphate synthase deficiency. There you go.
Yeah.
And yeah, it's a mutation of CPS1. But the thing with this disease is this mutation can happen in different spots in this CPS1 gene. And this infant happened to have inherited an ultra rare mutation from its father. So they had to find a way to fix this mutation effectively.
Yeah, exactly.
Yeah.
And I just wanted to go through the kind of timeline of the study because it's quite stunning, right? So
it is amazing. And this figure is in the New England Journal of Medicine,
yes,
if you want to read it.
So the baby's born. Then after the baby's born, there's a genetic diagnosis that's made. Then after that, they immediately made a patient-specific cell line. So
yes, with a specific mutation
exactly.
from the patient.
And then they, using that cell line, they tried to figure out which might be the best genetic approach to fix the mutation.
Mm-hmm.
And then they so
tested
super
it
rapid.
in monkeys and two mice models.
Exactly. And then by the age of 6 months, they had it in the patient. They got FDA clearance and they had it in the patient ready to go. So, I mean, that's completely stunning to get that much work done. And can you imagine, by the way, the guys that were doing the people that are doing the work thinking how much of a rush they're in? Because they know full well this patient the whole time is accumulating ammonia.
He must have been
very, very toxic.
Exactly.
And they're like, oh God, we got to do the CRISPR, we got to get the mice, blah, 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 blah.
Exactly. Every moment counts. It goes to show when you have a sense of urgency, you can get so much stuff done. like the COVID vaccines.
Right, right.
Just as background, Sam, as a clinician, do you want to say, what the symptoms of this disease include? If the baby makes it past like the super early stages of life.
Yes. So it is. So the defect is in the liver, and that's key to the therapy as well. The defect's in the liver, and the defect is due to the urea cycle. What the urea cycle does is detoxifies ammonia.
Mm.
So if you can't detoxify ammonia, you accumulate ammonia, and it's toxic to the brain. So you would get neurological disability. So,
and it means like the baby can't digest proteins properly.
Yes.
Because of the ammonia breakdown not working. And the CPS1 gene encodes for a protein that is part of this urea cycle.
Yeah, that's right. So the neurological disability would be I don't know exactly what it causes, but it would be things like I would guess things like seizures and comas, and you wouldn't be able to walk,
just
you wouldn't be able to speak.
Permanent brain injury, basically. Yeah. So it's really severe and but like the good thing about this like disease is that you can know the exact mutation that's causing it, which is why it's become a bespoke gene editing case. And here we can jump a little bit into CRISPR versus base editing. So I did my undergrad at Berkeley, so I love CRISPR.
Teach us. Go on, I'll sit back.
Everyone knows about CRISPR gene editing. But this is actually an altered form of CRISPR gene editing. So whereas CRISPR, it makes these double-stranded breaks in your DNA. Your DNA has 2 strands, but CRISPR makes breaks in both strands because that's how it works. And one of the disadvantages of that is it might lead to more off-target effects and unwanted damage to the DNA. But here, this is a form of editing called base editing, ABE, adenine base editing. So what makes this different is this only edits one strand of the DNA, so you don't have to do any double strand breaks. And this is specifically for turning you've got the 4 DNA bases, it turns the A's into G's, basically. So that's why it's adenine base editing. And they use that, and the advantages means that it's more precise, you get fewer off-target effects. And here you can use ABE for this specific mutation. Yeah. And obviously there are other types of BEs depending on what base you're trying to edit.
Yeah. And thank you. That was good. That was a good rundown from the Berkeley person. But the other thing is that so we're talking about a gene in the liver, right? So what you could do is, and this was my question as soon as I saw the study, right? So what's the point in editing the specific mutation, why not just give back the full length gene, right? Because that would be much easier. Like not worry about editing the gene, but actually just give back CPS1 full length in the liver, easy to do. Why not do that? But the nice thing about this that would not achieve would be that this leaves the CPS1 gene under its own native expression regulatory control.
Yeah.
Right? So you can get very tight regulation by the body's own ways of regulating the expression. Whereas if you put in the gene via a vector, via an exogenous vector, then you're using an exogenous promoter and it doesn't get the body's own native control.
Regulatory like system.
Exactly.
Editing.
So this, in other words, is a much more precise way of making sure the gene is not only wild type, but also expressed at the correct level at the correct times. It's much cleaner in that way.
Absolutely. That's such a good point, because there are other therapies that, like you said, provide the correct copy of the gene, maybe at like the RNA level or, but like this corrects the actual copy in the liver cells, in most of the liver cells, I believe, because it's very effective, this therapy.
Yes. And you can give it again and again.
Yeah.
So if the efficiency is not 100% first time, you can, and they don't know, by the way, how efficient it was.
They don't know yet. All we know from this study is the babies received 2 doses.
Yes.
Yeah.
And we should say the baby's well, by the way. We should have said.
Oh, yeah. That's
the baby's well.
Forgot to say the baby's well.
The baby's well. And,
so far.
And the ammonia, the key bit is the ammonia is controlled.
Ammonia has gone down. The baby can tolerate more protein in its diet. Do you know if it's a boy or girl? Forgot about this.
No.
I love how they leave the gender out of it.
It feels like a key feature. No, I don't know.
Gender neutral, very Berkeley. But the applicability of this therapy is so exciting, because apparently 90% of these diseases causing caused by these genetic variants. Sorry, I was meant to say 90% of diseases genetically similar to this are caused by single base genetic variants, which means you can use things like ABE.
Yeah, you mean like broader conditions of like metabolism.
Yeah,
due to defective genes in the liver, which aren't this condition but are kind of similar conditions, have also an individual mutation.
Of diseases caused by genetic variants.
Yeah, okay.
They're all caused by just one single base mistake.
Yeah.
Yeah. So this is like for all sorts of diseases that are genetic.
Yeah.
Which is crazy.
So it suggests that we can not only, this is the first time this has ever been done, but it suggests in the future we might be doing this for all kinds of babies with all kinds of conditions.
Exactly. For diseases where the mutations happen in different spots in the gene, which is why you can't just have a off-the-shelf gene therapy.
Yeah.
Like cystic fibrosis. You can do it for cystic fibrosis, which has well-known common mutations, but not for something like this, which is ultra rare.
It's exactly. That's
rare
the key.
and ultra rare.
That's the key.
Yeah.
Yes, precisely. There's an interesting consequence of this, a kind of drawback of this approach as well, which is that this baby will need everlasting, lifelong immunosuppression.
Yeah, that's true, because you want to tolerate the lipid nanoparticles that it's been delivered through and not get it.
But also the protein that it makes. Because it starts to make this wild type protein at 6-7 months of age.
Yeah.
It's a protein that the body has never seen before. So to the body, it looks like a foreign protein. It looks like a virus protein or something like that.
Yeah.
So the body would actually mount an immune response against the protein, even though it's a normal, healthy protein. It doesn't know that.
Yeah.
And so, unfortunately, the baby will require immunosuppression for life, which is quite an important drawback of the approach.
Absolutely. And also just like pragmatically speaking, the amount of resources taken to create this one bespoke therapy.
Oh, yeah. Yeah. Very expensive. This would be definitely in the millions.
Yeah.
Easily in the millions to generate this therapy.
Exactly. And this baby is lucky in that like a lot of researchers can expend their resources to work on this as a research project as well, but obviously to save its life. But, what about the next baby with the CPS1 mutation? What if it's already been done so they can't use the resources to create a therapy?
Yeah.
Yeah.
So there's definitely some things to figure out in order to get wider benefit from this kind of approach.
Exactly. But it's still a huge win, landmark
Stunning.
approval. First in class genetic therapy. So it's amazing.
It's beautiful. It really is.
Yeah, and it's just a follow up from the first approved CRISPR gene therapy by Vertex, and now you've got this.
Yeah.
Within 6 months. It's crazy.
Yeah, exactly. So that's for sickle cell beta thal, right?
Yeah, exactly.
And that's a nice one because this shows quite how patient specific this is, because this is not only for one condition. It's not even for one gene. It's for one mutation. Whereas the Vertex one is the same gene therapy for 2 conditions.
Yeah.
So it doesn't even is kind of condition agnostic. It works the same way in every patient. It just knocks out it disrupts the expression of a gene, which then fixes both beta thal and sickle cell.
It's beautiful.
Which is so it's completely different approaches, right?
And for them it makes sense because when you're a pharma, you have to make money, and that's able to serve more patients. Whereas here it's super bespoke, which is what I meant by it's rare and ultra rare, because it's like a rare mutation that they've never seen before in this disease, except in one other CPS1 patient. And this disease is just ultra rare in general.
Yeah.
So, yeah. Wow.
Awesome.
Cool. Well, that was breakthrough number 1.
Next one.
What's breakthrough number 2, Sam?
That's a good question. This one's from France. I was getting myself confused.
Oh yeah, this is the one in France and the UK. There you go.
France and the UK, yeah. Led by so I want to pronounce it. It's the
name of the
Petit Salpêtrière Hospital.
Very good. I couldn't have said that.
And in the UK, Brighton Sussex Medical School.
Ah, nice. And it's this is published in The Lancet?
The Lancet, yeah.
Nice. I love the name of the study.
Miracles.
Miracles. Not spelled in that way.
No, that's nice. I didn't see that before. Miracles. Okay, so this is a really nice, simple, emerging potential therapy for ALS, motor neuron disease.
And it's phase 2. That's why it's still emerging.
Yes. So exactly. So patients aren't going to be able to benefit from this today. They won't be able to benefit from this next year. But maybe in 10 years they will, or 5 years they will. So there still needs some work to be done, but it's very exciting. Mm-hmm. So just quickly on ALS. So ALS, also known as motor neuron disease.
Terrible, relentless disease.
So Stephen Hawking had ALS. Mm-hmm. It affects the motor neuron. So it affects your ability to move. It affects your ability to do things like handwriting. But more concerningly, it affects your ability to do things like swallowing, speaking, and then also breathing. And that's why it's so severe and why it's so deadly, is because it affects your ability to actually breathe.
And the average survival of someone with ALS after diagnosis is ridiculous. Something like 3 years?
It's very short. So there's a massive unmet need. It's not that rare. It's reasonably rare, but it's not that rare. I mean, I've met a number of patients with ALS. Mm-hmm. I wouldn't have thought I would, but it kind of shows you how reasonably common it is that I've met a few patients with ALS, and there's only one therapy that's proven to extend lifespan in ALS, just one. And it does extend lifespan, but it's not like brilliant, right?
Is this the Riluzole?
Riluzole.
Yeah.
Yeah, exactly. So the way that works is it does something called dampens down neuronal excitability. Not sure exactly why that works or how that works, but it stops the progression of disease and improves lifespan. So it's good that we have one, but we need more.
Yeah, exactly. That's definitely not enough. And this trial is important because it's talking about adding IL-2, interleukin-2 as an add-on treatment. On top of Riluzole.
Yes, exactly.
So give us a little background on IL-2, because I know you love interleukins.
So we talked previously, right, about how inflammation drives a lot of conditions.
Yeah.
Right. So we talked about how it drives cancer, atherosclerosis, lots of things. But turns out that inflammation, neuroinflammation, so inflammation in nerves, also drives motor neuron disease. And so the idea is that if you give low dose IL-2, interleukin-2, it's a cytokine, it suppresses inflammation. And that the question is whether that can stop the death of motor neurons and therefore slow the progression of the disease.
Yeah, and it's really interesting because, this is a huge study, randomized, double-blind, placebo-controlled across 17 centers in France and the UK. And when they first analyzed the results, they actually didn't find a significant difference between people with and without IL-2 as the added treatment. But then they redid the analysis and accounted for individual differences. And then they found a significant difference in survival, right?
Yes.
By adding IL-2
Yes.
to the ALS patients' treatment regimen.
Exactly. So they split them into 3 groups based on a marker of motor neuron loss. So it's something that gets released from motor neurons as they die. I can say the name of it. It's called CSF-PNFH. I don't like to say the name of things because it doesn't mean anything, right? Yeah. CSF-PNFH, what does that mean? Doesn't mean anything. So the CSF bit means that it's
cerebral spinal fluid.
Exactly. But the PNFH bit doesn't really mean anything. But it's released from motor neurons as they die. So it's a marker of how aggressive the disease is. And so in the third of patients who had the most aggressive disease, there was no benefit at all. But in the 70% of patients who had less aggressive disease based on this marker, there was a significant improvement in survival and function.
So people with like really low or no CSF PNFH can say the whole thing.
Yeah.
And that's really interesting because they related this to the effects of this therapy, obviously, to the immune system and immune functions, particularly about these Treg cells.
Yes, Tregs.
We love Tregs. T regulatory cells. And you can think of these as the peacekeepers of the immune system, where if you don't have enough of them functioning properly, then you get too much inflammation.
Yeah.
And apparently in these patients, the Tregs are not functioning properly. They're not in high enough numbers. But apparently the IL-2 treatment activated more Tregs and drove down some inflammation and neuroinflation markers in the blood.
Exactly.
Yeah.
I like the way you put it, the peacekeeper, what's that you said, right?
Yeah,
the peacekeepers of the immune system. That's really nice.
Oh, thank you.
I was thinking of a way to kind of describe Tregs as well. Peacekeepers of the immune system is really nice. They calm everything down. It's like a nice calming, presence.
Yeah, because you don't want to have inflammation forever. You need some agents to dampen the response.
Exactly. And IL-2 is required by Tregs to function. So the Tregs get in there and they calm everything down and they stop the inflammation and they slow down the disease. So I love how it's so simple, right? And by the way, it's really nice that, so they give the IL-2. My first question was, okay, so you give the IL-2, but do you have to give it into the CSF? Because
that's a great question.
Because if you have to give it into the CSF, that's makes the therapy much less pleasant because it means you have to do a lumbar puncture. You have to basically get in and around the spine. Quite unpleasant.
That's a great question.
But you don't have to do that.
Yeah.
It's subcutaneous, so it's just under the skin. So much less invasive than getting into the spinal compartment, which is much worse. So you just have to get it into the skin and that's it.
And the interesting thing was when they measured all these inflammation markers to measure the effects of IL-2, they saw the decrease in inflammation in successful patients within the blood, but not in the CSF, which was interesting. But it shows that you don't need the therapy administered through, in the CSF to see an effect.
Yes. Yeah, exactly.
But they also didn't see an effect in CSF of these same inflammation markers. So
yes, which then calls into question exactly how it's working, and is it in the which compartment is it working in, where's the suppression of inflammation, all this stuff. And I don't know how
all
how
that
all fits
matters
together.
is there was correct me if I'm wrong, 68% decrease in risk of death.
Yes.
In the patients with low or no CSF, P, and FH.
Yes, precisely. And beyond that, so it's critical, by the way, that in these trials you can look at different things as your outcome, right? So in this trial, they could have said, okay, I want to know my outcome is like a surrogate outcome, which is CSF, PNFH.
Yeah.
But if you say to a patient, you've got high or low CSF, PNFH, they say, I don't know what that is. That doesn't mean anything to me. But if you could use kind of hard outcomes where the patients really do care. So that's things like survival, but also things like swallowing, talking, walking, moving around, handwriting, speaking. And these things were all improved with the IL-2 cytokine.
That's incredible. And that's why like the design of the trial is so important. You need to really define these primary endpoints or surrogate endpoints. To speak the clinician language.
Yeah, exactly. It has to be things that patients, well, it doesn't have to be, but it should be things that the patients care about.
Exactly.
Patients don't care about what's in their blood. They care about whether
they
can...
don't care about these like random, very esoteric names that mean nothing to them.
Exactly. They care about whether they can speak still or walk still, right?
Exactly.
That's what's important.
And as long as the clinicians know how to, use this as a prognostic biomarker, then it's great. Another interesting thing about this study is it was actually disrupted by COVID. Yeah, like they were supposed to measure other endpoints like lung function tests and quality of life data. But because COVID was happening, a lot of patients couldn't go to the clinic to follow up, which I thought was interesting. But
wow, when did this study finish? I guess
not sure, but it was definitely
that's
ongoing
a bit of a shame, right?
in 2020, 2021.
Wow, yeah.
Yeah, just trying to look at the year. Yeah, just goes to show like studies that were ongoing in COVID. You can see the impact of them now on the results.
Yeah. Wow. Yeah.
Yeah.
There you go. So it disrupted a lot more than the immediate effects of COVID and lockdowns and everything else.
Yeah. Crazy. But yeah, and it also goes to show the importance of statistics. The study, like stratifying your patients.
Yeah. Yeah, but I think to me it makes perfect sense, right? That I think basically it shows that you need to get the patients early enough that they can benefit from the therapy. If you are waiting too long, or if it's too aggressive, and you may have already missed the window of opportunity.
That's such a good point.
I think that's
and
what it shows.
They picked early stage patients of ALS because they knew that they wouldn't be able to see a difference, likely not able to if they picked late stage patients.
Yeah, exactly. Yeah. So yeah, fascinating. And so we still need to see the phase 3 trial. But it could be a new therapy, very much badly needed therapy for ALS, which is very exciting.
This is really exciting, and fingers crossed for the phase 3 data,
which is underway. It's underway already. So
yeah, exactly.
We'll see.
Amazing.
Good study.
Very good study. What do you call them? Bangers of May.
That was a banger. I always see it's always obvious to me when there's a banger coming out. I saw that when I first saw that, I was like, bang, that's a banger.
You did pick the top journals. You Lancet, New
only.
England Journal of Medicine, and I've got a Nature paper for a third one.
There's not that many. At one point, maybe I'll give you a hot take about how many important journals I think there are.
That needs to be another episode. We
can
rate the journals.
Not a very big number.
It's okay. You're only going to publish in the top ones anyways, right?
Me?
Yeah.
No.
So you're not going to piss off the editors of the other journals that you're not listing. So Sam, what's our third breakthrough?
So this is a totally unique method to suppress malaria. Totally unique, completely new. Very nice. So there's a lot of anti-malarial measures that we have now, right?
Yeah.
So, for example, we can do nets insecticide nets. We could do vaccines. There's an approved vaccine. There are emerging vaccines, really good ones. We can do testing.
Yeah.
We can do medications, prophylactic medications.
Yeah.
We can even do monoclonal antibody therapy, right? To like bypass the vaccine and just give the antibodies.
Yeah.
Lots of measures. And indeed,
We've done well.
really good.
Yeah.
And indeed, since the turn of the century, so since the year 2000, deaths from malaria have dropped in half, which is great.
Yeah.
But it's now slowing down a little bit.
Plateauing, isn't it?
Plateauing. It's come down, but it's plateauing a bit. There's progress to be made. One of the reasons that the plateau is happening is because the malaria mosquitoes are developing resistance to the insecticides that we're using in nets.
Ooh, this is like, it's just like AMR.
Exactly.
It's the mosquitoes developing the resistance.
Yeah.
Wow.
Antimicrobial resistance.
Yes, sorry, I should. Oh,
That's-
you're
that's
good
you-
at this. Yeah, you're correcting me again.
That's your job. You're meant to say.
Yes, I shouldn't short form everything.
So,
and it's
just
still
tell us
huge.
where the study is from and where it is, the journal.
Oh, this one.
Yeah.
Oh,
just to
in
make sure.
Nature.
Yes. And
Yes.
it's from Harvard.
Yes, from Harvard.
There you go.
Just
So-
to touch on the beginning of this
by
episode.
a bunch of international scientists from Harvard University,
Thank
saving
you.
the world from malaria. Thank you, international
Please don't
scientists.
kick them out. We can't not get political. Not even about science.
So
This is still a huge deal because despite the success we've had at the start of the century,
Yep.
Malaria is still a huge public health
Yep.
issue. I think the numbers are as of 2022, there were still around 250 million cases a year with 600,000 deaths, mainly in sub-Saharan Africa and South Asia and other places in that part of the world.
yeah,
And not all of them were able to access all those resources that you just listed.
and it's mainly kids, by the way. It's mainly children under 5 that die.
Yeah.
Which is why we need to make progress. So, and what the innovation is, like I said, totally unique, is that they've built a mosquito net which is embedded with anti-parasites. So rather than trying to target the mosquito, you actually target the malaria parasite instead.
That the mosquito is carrying.
Exactly.
Yeah.
So that's never been done before.
Yeah.
Super nice approach.
It's so smart. It's like tackling the root cause of the problem and not just the vector of the disease, but like the actual disease causing agent.
Exactly, yeah.
Yeah. And tell me, how did they find this anti-parasitic
So they
agent?
did a really nice screen of a set of known anti-malarials, anti-parasites, which have not been approved yet, but are kind of going through the process. And they tested them to see which is the most effective, basically, to kill malaria. And they picked 2 of these. They picked 2 rather than 1 because it just reduces the risk of resistance.
Yeah.
The other thing they did, which is super smart, is that the malaria parasite, spends some of its time in the mosquito, right? But one of its stages of its life cycle, there's only 15 or 20 individual parasites in the mosquito. And the drugs target the parasite at that stage. So you can imagine that also suppresses the risk of resistance. So if you get malaria yourself, you'll have billions of unfortunately, of parasites inside you.
Yeah.
So if you try to kill it then, it's a bit more hard and the risk of resistance is much higher. Whereas if you try to kill the parasite when there's only 10, 15, 20 of them, it's a hell of a lot
You're
easier.
nipping it at the bottleneck before it explodes in reproduction.
So, and that's what they've done. And then they embedded them into nets. And it turns out the bottom line is that if you have a mosquito that comes into contact with the net, then it eradicates the parasites. 100% of the parasites are gone.
That's incredible. And I noticed that they were targeting, because there are 5 strains of Plasmodium, this parasite, that are responsible for for malaria in humans. And they picked the most threatening strain to do the study in,
Yeah.
which is good.
Yes.
Yeah, because like there are different strains cause different severity of the symptoms. But this one is can't say the name, Plasmodium falciparum.
Falciparum. Yes. Yeah.
There you go.
Exactly.
So it's great that they picked the most dangerous strain to target.
Absolutely. Yeah. The number is something like 48, I think, or 50 countries have eliminated malaria so far. So that means 0 cases of malaria in the last 3 consecutive years. China is one of them.
Yeah.
So 50 countries total. But there's still a long way to go. But if we add this approach, so anti-parasite nets on top of anti-malaria nets, by the way, you can do both at the same time, as in anti-insecticide and anti-parasite
Just
in the
embed
same
them in
net.
the same film or the net. Yeah.
Yeah. Plus the vaccines, plus the antibodies, plus blah, blah, blah. Then we can drive that number up, right? And maybe we can even eradicate malaria from the world.
That's incredible. A 10-prong approach.
Yeah, exactly. Exactly. The malaria life cycle is fascinating. It spends a bit of time in the so the way it works. It's the parasite's in the mosquito, right? Then it bites you. It goes to your liver. It proliferates, and then it bursts out of the liver. It goes to the blood. It proliferates in the red blood cells. It bursts out of the red blood cells, proliferates more, and then you get bitten by another mosquito, which then takes up the parasite, goes to someone else, and that's how it spreads, right?
Yeah, and it has to be by the female mosquito.
Yeah.
There's a particular name to the female mosquito. I forgot what it's called.
Female Anopheles.
Yeah, there you go.
And all of those measures, those bunch of methods that we have, target essentially the malaria life cycle at each individual stage. Like we hit it at every stage we can.
That is the most comprehensive way to get rid of it. Eradicate it. That's amazing. When do you think we'll eradicate malaria? Sam,
I think it's probably fair to say that I'm more optimistic than most people about various things. I don't know.
20 years? 50 years?
I don't know. What I would say is I think we can eradicate it. What do you think?
I'll be optimistic and say within 20 years.
20 years.
Yeah.
Let's do it.
Yeah. Within our lifetimes. Lifetimes. Yeah.
I agree.
That's amazing. Yeah. Keep the scientists at Harvard.
Yeah, thank you. I always feel like I should say thank you to these people who are doing incredible work, right? I never do.
But we just get to talk about their results.
I should say thank you, Alexandra Probst.
Let's start doing that for now. We'll thank the corresponding authors.
We appreciate you. Sorry, and Flaminia. Carataricia.
I'm butchering all these.
Thank you, guys. I really appreciate it. I mean, genuinely, I appreciate it. The work they do is awesome.
Yeah. No, it's amazing because we're scientists. We know how long it takes to do one scientific study.
Oh, for sure, yeah.
Yeah. And ours, the ones that we didn't even involve.
I didn't even cure malaria.
What are you doing
boring.
with your life? Wow.
Yeah.
Well, that was an amazing May.
Okay, can you quickly summarize the 3 things that we...
Right. So, today, we talked about the 3 medical breakthroughs from May 2025. The first one being a landmark study and approval of a bespoke gene therapy using base editing in an infant with a CPS1 mutation. And the second one... Oh, do you want me to finish? I was going to give you the honor.
We should have done a practice. There's no practice. The second one is a new emerging potential therapy for ALS.
And the third one, we just talked about a new novel way of targeting malaria by creating mosquito nets that have these anti-parasitic compounds in them.
Fascinating. Wow. And the last one, I know I said it, but just to underline that, 100% efficacy, by the way, in eradicating the parasites in the mosquitoes.
You need to add that to your list of 100%.
I know.
Things.
I've got it in my head. It's growing.
Yeah. Amazing.
Awesome. Okay. Well, nice to see you. Let's hope the sun
comes back. It's bank holiday weekend and the sun likes to hide.
It is.
Yeah. Well, we'll come back with the biotech deals from May 2025 for
Oh,
the
I'm
next
excited.
episode. So yeah, be on the lookout.
Ciao. Bye bye.